Hello, and welcome to POMA Does, a podcast produced by the Pennsylvania Osteopathic Medical Association. We provide a voice for osteopathic medicine and share insights on issues important to osteopathic physicians, residents, and students, as well as those who embrace the osteopathic philosophy. POMA's mission is to promote the distinctive philosophy and practice of osteopathic medicine for our patients, our members, and the communities we serve. Thanks for tuning in.
Hello, my name is Joe Zawissa, and I'm a POMA member, past president, and helped to develop the podcast series. And I'm a private practice physician in Orwigsburg and Schuylkill Haven, Pennsylvania, up in Schuylkill County. I run a small private practice with my sister, and before his retirement, my dad was with us too, doing primary care. And I'm joined today by Dr. Amy Capuccia, who is a family physician too. And I'm going to have her tell us a little bit about herself and why she's here.
Good morning. I'm Dr. Amy Capuccia. I currently live in Elverson, Pennsylvania, and I have a practice in Glenmore. I have a private practice now, and we've been open only since February of 2023. Prior to that, I was an employed physician at various places, most recently in Florida. I did a short stint at a private practice up this area that just didn't work out before I opened my own business. And the reason I'm here today is just to go over different business models and different opportunities in private practice that POMA members or any other physicians have available to them that maybe they didn't think that they could get out of the system and they didn't think that they could run their own show. I'm just here just to tell you that it's very rewarding and you have a few different options, but I'm a direct primary care physician and I own my own practice, and it's been the most amazing decision that I've ever made.
Great. Well, thank you. So as I said, being in primary care myself in a small practice, I've heard a lot about direct primary care. I've heard there's a lot of benefits to it. I'm wondering if you can tell me what your typical day looks like, how things tend to go for you.
Sure, absolutely. So direct primary care, it's a very small niche, but it is growing rapidly over the past 3 years. So direct primary care models started, I think, back in the 90s. And it was just kind of an opportunity to take yourself outside of the employed model. That was, the 90s is when everybody started becoming employees. And we thought that was going to be a great idea. It was going to take the hiring and firing away from us. It was going to help us with sending in payments and doing the administrative stuff that maybe a lot of physicians weren't wanting to do at that time. And then I think we trained business ownership out of our residencies and out of our med schools. We didn't teach business. We didn't teach that, you can go hang a shingle and do this. So we said, oh no, the Medicare guidelines are too much. You absolutely can't do it on your own. You absolutely do need administrative help. And gradually that eroded our autonomy. And I think we're seeing that at a peak right now where there's a lot of physicians leaving medicine for various different reasons. Either they're going to administration, they're like, it can't beat them, join them, or I just have to do this to preserve my lifestyle. Because right now, I don't think it's a surprise if I say that physician satisfaction is probably an all-time low. And the reasons that we went into medicine in the first place, some of us are forgetting that. So when you take really high-performing people and then all of a sudden you put them in a hole and tell them they just have to see X number of patients a day and you get 20 minutes and sometimes you only get 15 and sometimes you're double booked in that 15 minutes and you go to bed at night. This happened to me. Going to bed at night going, what did I miss today? I know I missed something. I saw 20 odd patients a day. I was supervising a couple mid-levels. I had to, check my inbox. I'm sure I didn't get through that. What if I missed a lab result? All of those things where you're just having too many tabs open at one time. I never thought that I would dislike medicine. During COVID, I think a lot of us came to that realization of we're expendable. They are laying off physicians during an epidemic. Who would have ever foreseen that? We don't actually need doctors. But you never thought that outpatient specialists, outpatient surgeons, rheumatologists, primary care, people were being laid off. And I just thought, really do not know what we do. They do not respect what we do. They don't value what we bring to the table. And when you look at the people making decisions, they weren't other physicians. So you have a group of highly motivated, high performers that became just employees. Years before that, I had started feeling that way. I was practicing in Florida in a value-based care system. Well, they call it value-based care now. It was Medicare risk-adjusted system. Value-based care sounds so much nicer. So I did 16 years in that model. And those are the three big models of care right now. So you have value-based care where you're getting reimbursed for, quote, performance and maybe outcomes. I think a lot of it has to do with how convincing are you to your patients that they should do all of the preventative screenings. They should come in every X number of months. We had a very good protocol for our patients. We saw them every 3 months. We made sure they had all their things done, and it was okay. It wasn't bad. The pay was really good, but I didn't feel like I was doing anything extraordinary, which I did look into that as well. So I looked into, continuing the value-based care just under my own practice, continued, going into a traditional fee for service. I looked into, some different EMRs that would have made that really easy. And I think that that some of the technology you can use does make it much more likely that you will succeed in today's current industry, using the technology and using a really good EMR, so making that investment. So that was another option that I looked into. But years ago, I had just on a whim gotten an email from the DPC Nuts and Bolts conference. And I was like, what the heck is this? That was about 7 years ago. And I went to the conference. I convinced my husband to go because I've always wanted to run my own show. Mm-hmm. I've always run other offices for other people. And it's like, I'm actually pretty good at this. I can do this. We went to medical school. We can learn business. This is not harder than managing patients' health in the Krebs cycle. Like, we definitely can do this. So I'm a huge advocate for physician autonomy. But direct primary care gave me more of that traditional feeling that I grew up with. I grew up in a semi-rural area called Twin Valley. In Twin Valley, we had a medical center there, and it was run by Dr. John Moser, and he was very active with the Amish community. He was active with Reading Hospital for their residency. I went to St. Joe's, which was, quote, the competing hospital because we were the osteopathic side. But he was phenomenal. And I just thought that everybody had an x-ray in their office. And I thought everybody drew blood in their office. And I thought everybody just took care of everything from birth to death like he did. And I was like, oh, yeah, that's what I want to do. And then I got into medicine and was like, oh, they want us to refer everything out to a rheumatologist or an orthopedist. I can't splint their arm anymore. Why can't I splint their arm? Why can't I splint a finger? Why do I need to send some basic injuries to an orthopedic specialist and my patient can't get in same day? Some are better than others, definitely about getting the sports med and sports injuries in. But I just saw all of the things that I was trained to do being taken away from physicians, from primary care, referred out to some other physician in the group. I need something that's going to allow me to practice to the highest level of my training. The highest level of my training is doing procedures, doing dermatology, doing EKGs, women's health, everything that I was trained in, I didn't want to lose. There was nothing that I didn't like. Direct primary care really seemed to be the branch or the business model that would give me the most autonomy, the most say over how long of an appointment a patient needs, how often I see them back, and not have to worry as much about, am I going to get paid for this? Did I put the right code in there? Did I bring them back too soon? If I see them and I want to, as a new patient, and I want to flush their ears and I want to do a skin biopsy, I don't have to say like, oh, sorry, can you come back in 24 hours? Because I cannot bill these two things on the same day.
Right.
I don't have to worry about the billing part of it. I don't have to worry about if I pick the right code. I still do for ordering CAT scans and ultrasounds and anything bigger outside my office. I relearned how to draw blood, so that really ups the patient satisfaction. They know if they come into Dr. Kabuch's office and they need something, most of it can be done right there at that time. They don't have to reschedule. They don't have to come back. Patients are busy. They don't want to be coming back 2 and 3 times to the office to resolve all of their issues.
Yeah, you hit on some great points there. I mean, and I think probably the biggest one, physician autonomy, we know is a huge cause for burnout, which is a big topic right now. And yeah, you definitely lose that. The other thing I think you said that was great about practicing to the full extent of our training. I vividly remember during residency, they had a Coumadin clinic, and, I knew I was going into primary care and I wanted to learn to manage Coumadin. And they said, oh, don't worry about that. Your pharmacist will take care of it for you. And when you're in private practice, you are the pharmacist. You're the everything, You don't send your EKGs right to a cardiologist. You read it. And I think that's a really important point, is that we should be practicing to the full extent of our training. I think DOs have always done that a little better.
I mean, as a DO, I can also add in manipulative medicine. I don't have to refer out to the chiropractors. I do have some patients who go to chiropractors. We co-manage care very nicely. So some patients come from over an hour away. So if they need multiple treatments, I may say, let's find a good chiropractor in your area and we'll co-manage and I'll speak with them and get things going. But a lot of them do just want to come to us. They also are tired of not knowing what, quote, provider they're going to see in the office. They had my name on their card for the HMOs, but I had 5 mid-levels working under me when I worked in Florida. So they were like, well, I have this lady's name on my card, but I keep seeing one of 3 or 4 different people every time I'm sick. I would try to get into every visit for at least 5 or 10 minutes, but that's not good enough. Right. I always felt like I'm sitting there taking somebody else's word for what the exam was like, still kind of doing a brief cursory, like lift up their shirt, make sure they don't have any, skin cancers on their back, listen to their lungs real quick, but you're still not getting that full vibe. You're not sure whether someone asked the right questions to get to the right conclusion.
Exactly.
And a lot of medicine is teasing out what is the right question. Did I find the right question? But you had asked me before what would make direct primary care, a viable option. What are the drawbacks? What are the benefits of it? We did go over, having much more autonomy over your schedule. I can build my schedule around my family's needs, which as an employed physician, that was never a possibility. I think that's a huge part of why physicians are feeling more burnout too, because you're supposed to put this business and this company over your own needs, over your own family. And I'm sure that definitely happened, before the 90s too. That definitely happened when people were running their own businesses, that sometimes I'm sure families felt like the patients came first, but you still had the ability to block off, a couple hours in your afternoon to go to your kids' thing. And then you could say, hey, I want to come back at night and see a patient or two. I don't mind that. With direct primary care, I can do Zoom. I don't have to worry about whether the state has decided or whether the insurance company has decided not to cover telehealth anymore for some ridiculous reason. I can say, hey, you know what? I'm already paid. You already put me on retainer. They pay me a fee every month. They don't have to feel bad about saying, oh gosh, I'm coming in again. I just have a little rash. So I was going to just let this rash go, but I already paid. She's mine. I find that patients don't really approach it that cavalier. They don't ever say, hey, I own her. They have a very good understanding of why I'm doing this. I'm doing this for them and I'm doing it for my family. And most of my patients definitely understand the need to put my kids into the picture. And I've gotten little notes back of, hey, I stopped by the office. I saw that you were at a kid's field trip. I thought that was really great. Just call me whenever you get a chance.
Oh, wow.
So they want to know we're human beings too.
Sure.
I think it makes us much more approachable if they know we are struggling with the same things they're struggling with. We're all trying to navigate social and work and financial things. The definite benefit of direct primary care is the flexibility of it. You can run your practice how you want. So the saying in DPC is if you've seen one DPC, you've seen one DPC. Some people are out there doing majority of sports medicine. Some people are doing men's health. Some people are doing women's health. Some people are, doing more counseling and mental health. And in family medicine, internal medicine, those things, you can tailor it really to what you enjoy. I think people are looking for physicians who will recognize that they're having problems and they take the time with them and really give them personalized feedback, not a checklist, not a, hey, you did all your preventative stuff. Kudos to you. Here's a $25 gift card from the insurance company.
Right.
You can go to Starbucks now. They're really just looking for someone who's going to sit down with them, understand where they're coming from, struggles they're having, what their kids are going through, and then be on call for them. When they call, they get me. And you had asked, isn't that hard being on call 24/7? Not really. I mean, I have at the max, I'll probably have 600 patients. And depending on the need, they're high need patients. I might only have 400 to 500 patients. So, when you're in a call group with 10,000 patients and when you're on call and you're getting 60 phone calls over the weekend and you're just burnt out from the weekend call, that's not happening in direct primary care. Some weekends I get 0 calls. I can go 2 or 3 weeks with no calls. Right now I have 170 patients, so it's not at the max clearly. But my patients, I've taught them from the beginning that if this is a semi-urgent thing, send me an email through the portal. If this is urgent, pick up the phone and call me. We utilize Google Voice just to keep the cost down. So Google Voice will actually work as my answering service. So they call the office, they get my recording, and then they'll leave a message. Google Voice transcribes it, send it to me as a text. Gotcha. So I can see, is this something, if they're calling on Sunday just to say, hey, I can't make it to my appointment on Monday. Can you call me back to reschedule? then I just leave that in the voicemail and I get it, take care of it Monday morning. But if they're calling saying, hey, Susan has a fever and a rash and I'm not really sure what to do, then I pick up the phone and call them back. Or sometimes I just pick up the phone if I don't have 10 other things happening around me. I'll just pick up the phone and answer.
Yeah.
I don't find that there's an abuse of the call system. And I think that may be a difference because it's a personal relationship. They know that when they call, they're getting you. And they don't want to irritate the doctor too much either,
Yeah, I get that a lot too. We cover our own call, my sister and I. And, a lot of times the first thing out of the patient's mouth is, I'm so sorry to bother you on a Sunday.
Right.
I always tell them patients don't stop getting sick just because it's 5 o'clock or because it's the weekend. And, well, that really helps a lot. Certainly, this is a model I've looked into before for myself. And I'm not sure that it's right for me right now, but that's one of the things that can be really intimidating is the thought that, you just have to be ready to drop everything at seconds notice because a patient called. And it sounds like it's not really that way.
No, it's not like residency call where, you're in the hospital and someone calls and you've got to run there. My goal is to provide good enough care that patients don't hit their deductible for their insurance if they have it. So that's why I tell them, I said, listen, I'd rather you call me before you go to an urgent care. I'd rather you call me before you go to the emergency room. There are some things that they're still going to need the emergency room for. And patients need to know that. We always recommend that patients have a catastrophic plan of some sort.
Absolutely.
So when you're looking at the payment model, so the patient's paying you X number of dollars per month. And it varies. Some people charge $50 a month. Some people charge $100 a month. It really depends what you're putting into those services. I've seen some places that are charging $125, but they're more of a medical center and they're offering gym membership plus labs plus chiropractor on site plus a massage. Some people are really doing big things and they're going to charge more. And maybe that makes sense to a patient who's like, well, I'm going to go to the gym anyway. So $25 for a gym membership is nothing. $100 for my doctor is pretty dang good. And I get a couple doctors for that. You can do it however you want. I looked into joining a bigger practice and doing the startup for the direct primary care under an urgent care model and then offering primary care with that. It was just too big for what I wanted. I wanted a nice, small, I can control this as I get started and then grow up from there if I decide to dream big. If I decide to take it on and, get my own place. Right now I rent. So the big decisions that I had to make when starting my practice. So I originally thought I was going to buy someone's practice as they were going into retirement. They still have paper charts. They've been in business for a long time and it just didn't work out. So long and short of it, it didn't work out. It would have been a lot of work for not great reward. There wasn't a lot of flow already in there. There wasn't anybody making sure that bills are being paid. So I just felt like that would have been taking on too much debt to take over this person's practice and still paying them for their debt just didn't make sense to me. I'll just take on my own debt just for me, and not have to clean up anything. So then the next decision became, okay, where do I want to be located? I live in a very rural area. Did I want to be right where I am? 25 minutes away is a non-rural area. So I went right to the cusp of that. So I went at the corner of 401 and 100. So the one side of 401 is farms and trucking companies and dairy and produce and meat farms. And then the other side is suburban sprawl. To me, I said I could still deal with my people who are the more country rural. I'm only 10 minutes away from some farms and things like that. And I also have the other people who I can get the volume from to make sure that I can survive. So picking the placement of your office is very important when you're sitting there going, I'm changing the model of care that patients are used to. They're going to call, they're going to say, great, there's an actual doctor taking new patients and she can see me today. That's amazing. I want to go. And then they're like, you don't take insurance? What do you mean you don't take insurance? You have to explain to them, listen, insurance is not healthcare. Insurance does not guarantee you healthcare. They will say all over your forms that just because it says online that this will be covered, they don't guarantee that they're going to cover it for your $1,200 a month for your family. So people are paying to get something that may or may not cover the services they need.
Right.
So I tell them, like, you were paying a fraction of that. I decided on $90 for adults. I started at a lower rate, but then I was like, I want to provide more. So in order to provide more, I need to charge more so I can offer more services, hire somebody to help me so I can offer more services. So I charge $90 a month. I charge it quarterly because to me, I was sitting there going, okay, if they just give me $90 on their first visit and then never come back again, I just lost money on that transaction.
Sure.
A lot of it is getting your head around that business thing of it's okay to make money off your services. It's okay to charge what you're worth. and say, they got an hour and a half visit, that if they never come back again, then I got $270. And that would be about an hour and a half visit with a physician if they were paying cash for that. But what they get for that is they get an additional 2 months of aftercare. So if they come back in, usually I'm bringing people back in a week or two, because that first visit is our discovery visit. And then we decide what labs need to be ordered. We hunt down all the old records. And then I usually bring them back in a week or two to kind of put it all together, make sure they didn't have any other questions, make sure they're satisfied with the level of care they're getting and that they didn't think of something else they need. And then at that second visit, we usually go over their routine screenings, their preventative stuff. How long has it been, since you had a PAP? We could do that here too. And then set up, another couple months follow up if everything's good. And if they haven't seen anybody and their blood pressure is 200 over 100, then we just see them an awful lot. So that has happened. That will happen in this glorious model that everybody's like, well, you cherry pick your patients. No way.
No.
You can't do that and survive, because word will get out. I usually recommend a meet and greet ahead of time just to make sure that patient is a fit for you. I usually just say, listen, we're open. The doctor will take 5 minutes with you. That gets them in. They get the feel of it. They get the vibe. And then it's not as scary for them to choose a different model of payment. And that's really the only thing that's different. It's a different model of payment, and it's a better model of service to your community and to your patients, because we know we can't do it in 15 minutes. We are doing this level of care. I've never had anyone ask so many questions. I've never had this level of care. There's a lot of people with a lot of complicated history, and they're willing to pay to have someone figure it out, or at least to be heard.
Sure.
The other question I get from a lot of people is like, well, isn't this concierge? This is catering to people who have money. It's $90 a month. The insurance companies are catering to people who have money. I mean, you cannot get insurance for $90 a month. You can't get anything for $90 a month. So as far as this is catering to the wealthy, this is concierge. The difference between direct primary care and concierge is concierge most of the time will charge that retainer fee and then charge your insurance on top of it. Okay. So it's most often a double billing system. You're paying for their time and for them to hold that slot for you, just like in direct primary care, but you're not actually paying for the service. The service is still going to be paid by your insurance company. I know that there's a lot of MDVIP. There's a lot of things out there that are direct primary care like, but are really concierge and do cater to people who have more expendable income who can get that higher level of care. When I chose this, I said, I know that there are going to be some people who still cannot afford $90 a month, but then I have the choice of saying, okay, you bring me your W-2. And if you really are in the poverty level, I get to decide what our scale is going to be, and I don't have anybody else telling me that I can't do that. That's not fair. That violates a Medicare rule because you have to charge the same amount you charge Medicare patients. So it is nice. You can say, listen, I can do my charity care here, or I can be so successful in my direct primary care that I open up a charity arm in a year or so and do what I want with my charity there. And I get to feel like I am tailoring my care every day to my patients. So they're getting concierge care. They're just getting it at an affordable, everyday American price. So there's so much information out there, and there's just a broad network of other physicians who want to see physicians survive, who want to make sure that physicians aren't burning out, that physicians aren't committing suicide, that, our suicide rate is way too high because we're not feeling like we're valued. So if anybody's thinking about it, there's so much information out there and more growing every day, because people who are doing this model of care, when we have a little bit more time, there's a whole network of physicians out there that want them to succeed in business. But there's a lot of opportunities out there for self-employment. And I really just want to be that plug for other physicians who are struggling with being an employee, and just tell them you can do it. Like if you made it through med school, residency, you got your board certification, you've done all the really hard things, that this isn't that hard. It's just a mindset shift.
Gotcha. Yeah, different than what we're used to, but
right.
A lot of things to think about here. And this makes me feel a lot better that it's an attainable model, it's an achievable model that we can do, and you don't have to be stuck in the way things have always been anymore. So
you have to just be good at a little bit of self-promotion too. You have to say, I have a good product, you need it. I'm big with social media. I didn't used to be, but now that I own my own business, I'm trying to be very consistent, putting something out there once or twice a week, all the time. And I'll have some patients come in and be like, oh, I saw you on Facebook. That's why I'm here. Fantastic. Good. I like the way you sounded and I like your philosophy. So I'm willing to pay for that level of care.
Yeah.
Aside from my insurance. So I think we just need to embrace some things are changing, and the idea that we shouldn't advertise doctors That was the model we grew up with, right? If you're good, they're going to come to you. You shouldn't have to advertise.
Right.
So if you don't put yourself out there, people don't know you exist and they don't know that you can provide them an amazing service.
You're right.
So even if you hang your shingle and your fee for service, use social media. Let your neighbors know, join the moms group, join the small groups around you. Really allow them to decide that they want to see you because you provide a service that they would like.
Yeah. Good. Well, thank you. I appreciate you talking with me. And I already have a list of questions for you for maybe a follow-up episode if you're interested. So
perfect. Absolutely.
Thanks, everybody, for listening. I hope this was as helpful to you as it was for me. Thanks, Dr. Fuccia, for the information, and we'll talk to you later.
Absolutely. Thank you for the invitation. I appreciate it.
Thank you for joining us for this edition of POMA Does. Be sure to subscribe to POMA Does wherever you listen to your podcasts, and tell your friends and colleagues to tune in. Learn more about osteopathic medicine and POMA on our webpage, www.poma.org, and join the conversation on social media. We're on Facebook, Instagram, LinkedIn, Twitter, and YouTube. Or email us at poma@poma.org. We'd love to hear from you. Join us next time for another edition of POMA Does.